Good evening, everyone. My name is Colin Davidson. I'm the president of the college and your host for this evening. I'd like to wish you a very warm welcome to this evening's live webinar. And this is where we hope we'll find some answers to the question on many optometrists' minds. Has the coronavirus pandemic changed optometry for good or bad? So really, optometrists and their patients have had differing experiences of the pandemic so far, from not working at all to working remotely, or really in significantly changed environments. The variation has been influenced not only by the restrictions of lockdown, but also in national guidance and regulations. So overall, I think we can agree that we've all faced significant challenges and uncertainty. So it'd be good to gain a greater understanding of each other's experiences, lessons learned, and how these can shape the future for individual optometrists and, of course, for our profession. So this evening, we've brought together a great panel of guests who work in diverse roles. We'll be finding out more about the optometrists' experience during the coronavirus lockdown and how it differed across the 4 nations for both them and their patients. We'll also be discussing whether this experience has changed their perspective on optometry and how they see their professional future and the future of the profession. Will it change for good or for bad? So I'm going to ask all the guests if they could switch on their cameras and unmute themselves and join me on the screen. So this evening we're taking a tour of the UK, and we'll be in the company of Tim Morgan. So Tim owns a community practice in North Wales, and he still finds time to be an optometric advisor to the Health Board and Vice Chair of Optometry Wales. So welcome, Tim. Kathryn Trimmer is the lead clinician at Duncan and Todd Group, who are based in Aberdeen. And Kathryn is also a College Council member for Scotland. And welcome, Kathryn.
Hi.
Janice McCrudden, who worked throughout lockdown in the Hospital Eye Service and on the Regional Health and Social Care Board, and is also a community optometrist based in Belfast. So welcome to you, Janice.
Hi.
And finally, we've got Shane Abbas Bhimani. Shane's clinical director at Specsavers, and he also works in glaucoma clinic at Moorfields Eye Hospital, and he is a College Council member for the London region.
Thanks.
So welcome. Thank you all for giving up your time this evening. It's great that you can all join us. So again, if you would mind just pop your cameras off for a moment, and we've got this evening the opportunity to ask some questions. So after our guests have shared their experiences, ideas, opinions, there'll be a brief Q&A session. You can submit your questions throughout the webinar via the questions drop-down box, which you'll find on your control panel. So if you're using a PC or a laptop, it's on the right-hand side of the screen. But if you're on a mobile or a question icon will be at the bottom of the screen. I don't seem to have the ability to share my screen at the minute, Kieran, on tech support, so I can't share the PowerPoint at the moment. Let me just do that so you can see what I was talking about. So hopefully you can see that. So these were what I was meaning. If you can see the little question marks, that's where you can submit your questions, or if you're on a PC, laptop, it's on the right-hand side of the screen there. Fantastic. You can also use this function to let us know if you're having any technical problems, or you can email events@college-optometrist.org for any technical support. Don't forget to make sure you've got all your windows and apps closed, and that you or anyone else using the internet aren't downloading or streaming anything during the webinar, because that might affect your bandwidth. So we'll be asking some questions, poll questions at the start and the end of the webinar. The questions will appear on your screen, and all you need to do is click the answer that you want and submit. So with that in mind, we'll start our first poll question. So the question is, which of the resources developed by the college have you found and used during the COVID-19 pandemic? So the questions will be on screen for about 50 seconds just while everyone votes. So we've got choices of guidance on adapted practice, in-practice resources, so the posters and infographics, additional online learning and events, alerts and updates, or I haven't found anything useful. So I can see the votes coming in. I know for one, I've used the time to take advantage of learning opportunities, and I've looked at some of the great learning modules on the college website and got some CET points ticking over with that. So I think we're pretty much at most people voted. So let's see what the results were. And well, we've got a fairly even spread among the guidance on adapted practice, with the online learning and events and the alerts and updates pretty much even. I'm really pleased to see that there's not many haven't found anything useful. I think there's been some fantastic resources, and the college team have worked really hard to get those out to us. And for one, I think it's been a great job. So let's press on with what I think promises to be, I think, fascinating and a thought-provoking event. So we're going to start with Wales and Tim Morgan. So Tim, if you'd like to join us again on screen, and welcome back. Thanks so much for taking part in this evening's webinar. I understand that your practice stopped seeing patients at the height of the lockdown, and you took on a much more strategic role. Do you know, it'd be really great if you could tell us a little bit more about that. So I'll leave you to do that.
Of course, thank you ever so much for having me, Colin. Yeah, so for me, the lockdown was split fairly neatly into two distinct chapters, really. The first being the transition into the lockdown, and the second being the lockdown itself, when we'd all settled into our new ways of working. So some thoughts on the transition first. I think the transition was a really difficult and anxious time. I think as clinicians, we're really used to making risk assessments on clinical scenarios and patients in front of us. As a contractor, which I am as well, I'm really used to having a considered business plan that's got a long-term strategy. And then suddenly, of course, something came that we were ill-equipped for, to consider an unknown virus and its impact on our team and our patients' health and potentially life. When the situation was changing day by day, it was an impossible situation. With that, of course, overwhelmingly, I'll just remember anxiety, and I'm sure many others listening to this will feel the same. With the guidance and with the clarity, and we were very fortunate in Wales that the clarity came early on, and that was very welcome when it did. Wales announced its strategy for what we would call the red phase, and that was the strategy ultimately was to reduce the active workforce. So around about 75% of primary care optometry practices were requested to close, meaning the remaining practices became hubs, primary optometry hubs, to see that essential and unscheduled care. So my practice was one of those that was asked to close, and it's a feeling I shall certainly always remember, locking the door behind my staff after they left and not knowing when it was going to be unlocked again was incredibly unpleasant and emotional, and done with a very heavy heart. Admittedly, it was done with very light shoulders, because I realized I was asking my staff to go home to where I would be confident they would be safer, especially in those early days where the PPE guidance hadn't been clarified so much. I have a huge amount of respect for those teams that did carry on with face-to-face examinations, both in primary and secondary care. That, you know, I say one more word on the anxiety. I think the Welsh Government launched access to free mental health support and access, and that was open to all health professionals across this time, and that is ongoing, and that is, again, really, really welcome. I think that's something that I think we should take away from this when we look back on the whole period, is the importance, because those mental health and anxiety challenges will be affecting many of our colleagues around us, and we need to have a good, robust conversation about how we can best support that going forward. So that was the transition into lockdown. And when lockdown came, the overwhelming impression and sort of word I was left with really was collaboration. And I saw a huge number of positives coming, great collaboration in a number of ways. So partly with furloughed optometrists, for example, helping out with volunteering for pharmacy and sorting and distributing prescriptions. Collaboration between practices, where we know the clinicians went to work in a neighbouring practice to ensure that they had enough workforce to maintain their hub. So that's really great. You know, disparate businesses working together as one profession, I think, is really inspiring, and we've got to hold on to that as we take that forward into the future. Also, practices into practice referrals to access independent prescribing, for example. We saw a great deal of collaboration between secondary care and primary care, with a huge amount of patients not able to access the acute hospital sites due to the COVID risk, but instead being directed to primary care to have data gathered to be assessed virtually. Now, admittedly, that was much more successful in some areas of Wales rather than others, so we should take encouragement with that, but also recognise the challenges that come with service redesign. The place I saw collaboration most of all, though, was strategically. Colin, as you mentioned, I was fortunate when my practice closed. I was privileged, really, to be given the opportunity to work for the Health Board in a strategic role. And part of that was a localised role, but part of it was working alongside a national effort. So the strategy in Wales was absolutely led with strong leadership from Welsh Government. That is absolutely, again, to be commended. But it was done collaboratively, with health boards inputting via their optometric advisors, with the profession being represented via Optometry Wales, and with the patient being represented by the Welsh Optometric Committee. And I think the evidence of that collaboration is really apparent, really obvious in the outcome of the strategies that we've had. So clinicians have been represented, and with things like the access to the mental health care and support, and also PPE being delivered to all the open practices in the red phase, and now all the practices in the amber phase as well. So the clinicians' plight, if you like, has been recognised, also the contractors as well, with the early guidance as to what amber would look like. We're now in the amber zone, and we had the guidance about 4 weeks before to allow contractors a chance to prepare properly. And also the NHS payments have continued and will continue through the amber phase. So the contractors are well represented, but also the patients were well represented. So now we face an unprecedented backlog in primary care, and there's a new prioritisation tool which is being used to make sure that, as a health board, I know that the practices and the patients are accessing those practices, and that only those most in need and most at risk will be seen in the most timely fashion. So for me, lockdown began with anxiety, certainly, but has very, very swiftly settled down into a time of real collaboration that I find actually gives us a lot of positives to go forward.
Tim, thanks very much for that really personal perspective. I think the anxiety, the anxiousness felt by many people is something that I've heard reflected in the conversations that I've had with friends and colleagues, and it has been a worrying time. But I think for me, the way everyone seems to have pulled together it gives me great hope and kind of hope for the future. And I think you've hinted maybe at new ways of working. What do you think are the lessons learned, and maybe how things could look in the future? Your kind of personal view, and maybe also how in Wales optometry might look.
Thanks, Colin. Yeah, so the future, I mean, it's always an interesting topic, but at this time more than any, looking into the future, we realise the possibilities are enormous. So we're looking very positively and constructively to the future, but we should begin by being wary, and I think we'd be paying the patients a disservice if we didn't recognise that at the moment, to be a patient is quite a precarious position. There are backlogs in primary and in secondary care. We need to really be mindful of that in our service redesign. We must also, I think, be wary of the desire to get back to normal. I heard an interview with our First Minister, Mark Drakeford, recently, where he explained that he's actually banned the phrase "back to normal" from his office. He recognises that he recognises the innovations that we've seen in all areas over the last few weeks, really, and months, of course, really show that a return back to normal is not right, and neither is it brave enough. We should be bolder for the future. So there are reasons to be positive. There's a great William Gibson quote that says, "The future is already here. It's just not evenly distributed yet." And I think that's a really good one to hang on to at this moment, because from that, I take it to mean that we don't need to invent a new future. Instead, we need to curate the future that we choose. So there's a lot of good practice that happens already in Wales, and we need to celebrate that. Nationally, also recognise that there's been some local developments that are really should be celebrated and scaled up. We also should look to our other home nations, and I'm really looking forward to hearing everyone else talk this evening, and to work with the home nations going forward when we consider what are the best aspects that we can bring, both in service design, in education, in workforce welfare, and also, of course, the big question of remuneration. So as a contractor, we've seen the remuneration model change dramatically over the last few months in ways that we couldn't have imagined in February. And although it's been really challenging, we found a way to make it work. And I think we can take a great deal of comfort from that and realise that we can go forward into a new way. The feedback I get from other colleagues and from the other optical bodies that I speak with is there is a real desire to end cross-subsidy of spectacle sales and to end the private patients subsidising the NHS patients. So it's a really good opportunity to be bold, to be mindful of being wary and slipping back, but taking the best positives and moving forward. I think the advice that I would want to give, if I could, is that we're all going through really vivid experiences at the moment, and all having fantastic thoughts, ideas, and reflections, and they need to be represented. It would be a real shame if those were lost. And the best way, of course, to represent those views is to make sure that you are, as individual clinicians and as contractors, feeding back to your regional optical committees, the ROCs as they are in Wales, and to make sure that those opinions, thoughts and experiences are being reflected and absorbed, so that it can all go towards making that bolder and better future for our profession, for eye care as a whole, and of course ultimately for the patients.
Tim, thanks so much. I think we would all have what's best for our patients and ourselves top of mind in these really, really difficult times. I was really taken as what you said about the possibilities, but still being wary. I think one of the things that for me maybe is still slightly unknown is how many patients are we going to be seeing who maybe have got some sort of sight loss that has cropped up during the pandemic that they just haven't done anything about. So I think the next few months will be interesting, and I think I agree with Mark Draper. We don't want to be going back to normal. We have to adapt, and we have to move on, and we have to grasp the opportunities. So thanks ever so much for your thoughts and views, and we'll come back to you later at the Q&A session. So thanks so much. So next we're going to be travelling to Scotland to welcome Kathryn Trimmer, who's going to tell us about the lockdown experiences for optometrists in independent practice. So hello again, Kathryn. So I understand you're not working now, but I believe you had a pretty hectic time at the beginning of lockdown. You were one of 2 independent providers giving remote support via telephone or video consultations 6 days a week across 41 practices. That sounds like a real handful. And you know, from my own experiences, I know how difficult it is to do a telephone triage, a remote triage. So it'd be great if you could tell us a little bit more about that.
Yes, thank you, Colin. Thanks for inviting me to the webinar. So the Scottish Government, when lockdown happened, decided that all practices would close, but yet every practice would maintain a virtual triage system for their patients, so everybody still had that point of contact for eye care. Optometry was already the first port of call for any eye problems in Scotland anyway, so patients were coming hopefully directly to us rather than their GP or pharmacist anyway. We were really to keep patients out of any face-to-face appointments where we possibly could, and each health board in Scotland set up their own emergency eye care treatment centres for those patients that did have, and it was really only sight-threatening eye conditions that they were seeing. Everything else we were to deal with remotely. So massive change there. The whole way you would assess risk, if someone had flashing lights and floaters, you would always want to see those patients, but the whole mindset had to change. And my role changed immediately from all face-to-face to all on the telephone and working from home, and all lone working, which is very different as well. So that really made me hone my history and symptom taking skills. Weren't able to rely on any visual cues that you would normally have. Often, I'm sure we all know that patients find it quite difficult to describe their symptoms, so you then move on to looking at the clinical signs, but we didn't have that available for us. So we had to utilise as technology as best we could. I would often get patients to send me photos of their eyes or do a video consultation. If patients didn't have the ability to take photos, I would sometimes get them to phone their neighbour to come through and take a photo through the window, just any way of getting a better confirmation of the diagnosis that we could get. We would get patients to use sort of homemade pinhole glasses. We would get them to look at red items in their home to check their colour desaturation, their red desaturation, and there was also apps that we would email to patients for them to check their own visual acuity. So where possible, we were still doing the same sort of tests, but remotely. And the vast majority of patients, as an independent prescribing optometrist, I was really surprised with how I was able to deal with them remotely without having to refer them for a face-to-face. But that obviously came with a lot more risk. And there was some patients that it was quite difficult to sit on that level of risk. So, you know, I'd phone them back and check in on them. And any patient that I did give a treatment plan to, I was very conscious that I gave them clear guidance on what to do if things changed and what alternative diagnoses might be and what to look out for. So I would often email prescriptions for them to their local pharmacy so they could access care straight away. Most of it was reassurance, and there was also conversations with their GP as well if the eye problem moved into more a general health issue. And I think the only negative was for those patients who weren't able to send me photos, who weren't able to deal with technology, and it made the decision-making process on what their diagnosis was very, very tricky. These patients were often very in the vulnerable category, and therefore sending them for a face-to-face appointment during the pandemic was really something I'd want to avoid, but you also want to avoid a misdiagnosis. So that was probably the most tricky part. The Scottish Government recognised the importance of independent prescribers, which was fabulous, and we were able to claim a higher fee for the virtual consultations that we did. And I think that increased level of recognition for the qualification filtered down to employers as well. So I'm looking forward to seeing how that goes forward. The governing bodies in Scotland, so the Scottish Government and Optometry Scotland, I feel have been excellent and gave us very clear and very regular guidance on what to do. And we also have a Scotland-wide clinical guidance app that was updated right at the beginning of lockdown with advice specific for COVID, which was really invaluable, being a lone worker as we all were. So on the whole, patients were generally very understanding. They realised that everybody was working in a very difficult environment. It's difficult to build a trust, the trust and rapport with a patient who you've never met before. And as I was triaging over the entire Scotland, the vast majority of patients I hadn't met before. So I think really going forward, if remote consultations are here to stay, video consultations are the way to go to reduce that issue.
Great, thanks, Kathryn. It sounds like a complete new way of working and a lot to get used to. So thanks for sharing that, and well done for getting through it all. I think we're all, you know, envious of some of the systems in Scotland, Wales, and Northern Ireland, where optometry are really the first port of call for eye problems. And you know, as an IP-optom myself, it's really encouraging to hear how IP-optoms have been respected through that. And again, this is maybe something we can pick up with Tim and Janice in the Q&A session, how IP has been integrated into it. But it sounds as though that there's lessons that you've learned again from that, and similarly to Tim, I'm going to ask you maybe how you think you can learn from those lessons, maybe how things will change, and your view of the future.
Yes, thank you, Colin. So again, I think there's a lot of things that the Scottish Government were looking at before lockdown that I think just got sped up when lockdown happened. So there was already a move towards moving patients like stable glaucomas out into the community for independent prescribing optometrists to manage. So I think the whole utilisation of independent prescribing optometrists is something that that worked very well and will obviously continue, and that process may perhaps be accelerated. I think video consultations worked really well, and I would love to see that being something that would be funded going forward, as it's a really good use of patients' time and our resources as well. And as I mentioned earlier, I found it surprising with how many patients you could deal with just by reassurance, so that it didn't really need to be that travel for the patient. Another service that was set up extremely quickly was teleophthalmology, which was a fantastic resource that the optometrists working in the emergency eye care treatment centres were able to link with an ophthalmologist, and was able to see through their video slit lamp what they were seeing on the slit lamp, what they were seeing through Glauc, advise optometrists where to look, where to move the lens so that they could see properly, and then be able to give a treatment plan remotely. So the patient didn't have to have a second face-to-face to see a consultant. And it also is a great learning tool for the optometrist. So any suspect diagnosis gets confirmation straight away. And certainly in my area and a few other areas, this teleophthalmology is something that is going to be continuing for now anyway, which I'm really excited to get to use. It's great for both patient and practitioner. And another really positive thing that I was conscious of during the pandemic is working across all health board areas. Generally, referral criteria and the way that each health board works is slightly different, but there was real collaboration between all health boards, and I found it very easy to navigate how to refer a patient in all health board areas. So again, that would be something that would be great to continue. With regards to opinion of optometrists, it's always been very high within our area. We've got a very good working relationship with ophthalmology, but I think the way that optometrists have kept patients out of secondary care where possible just shows the potential that optometry have, and I'm sure has increased the level of respect throughout all areas of Scotland. And finally, I think the lesson that I've learned is face-to-face is really the ideal, but virtual consultations really have a place, I think maybe long term, but I would just like to see how we can maybe bridge the gap for those who don't have the IT skills or the technology to enable everybody to be able to access virtual services.
Thanks a lot, Kathryn. That's great. I think your points about how things have progressed at a tremendous rate is just for me, it's been amazing as well. As I think I've been just how things have changed so quickly in such a short space of time. It's been really tricky to keep up with the pace, and I think as well. I mean, I've been just so impressed with the way optometry has stepped up to this, across the whole of the UK, and I am really pleased to see that our ophthalmologist colleagues are recognizing this and recognizing the contribution that optometrists can make to patient care. So it's great to hear that sort of reiterated from your perspective as well. So Kathryn, thanks very much for your time, and we'll see you later on the Q&A session. So I'm going to ask our next guest, Janice McCrudden, to join. So throughout the lockdown, Janice continued to work in the hospital eye service and the regional Health and Social Care Board. So welcome back. I think we'd all be interested to find out more about the hospital lockdown experience and how it may shape optometry both in community practice and in hospitals in the future. And then you also had a role in the Health and Social Care Board in Northern Ireland. So it sounds like your experience was kind of unique and varied. So it'd be really great if you could just share a little bit of that with us tonight.
Okay, thank you, Colin. Yes, as you say, I have a number of roles across various organisations, so I was definitely kept busy during lockdown. My main roles in the hospital are in low vision, paediatric and medical retina, and in the health board, I'm one of the ophthalmic clinical advisors in Northern Ireland. So in the hospital, the first thing that I noticed was that I work in a number of outreach clinics, which is outside the main centre, and we were dispatched to clear rooms and remove clinical equipment because everything was going to be reallocated to COVID services. So that was when you first sort of realised this is going to be quite serious, as in everything needs to be packed away and stored away. These rooms are not going to be used for some period of time. And then obviously clinics were starting to be cancelled. So we initially then had to start stratifying our lists of those that were cancelled and seeing who, when the clinics would start again, needed to be put on urgently or routinely, or what would happen to them. And then as time went on, we had to look at the review list going forward, because maybe the next month was going to be cancelled. And then there were still some new referrals coming in, not as many, obviously, because other services weren't working, optometrists weren't seeing as many, and other hospital clinics were cancelled. But there were still new patient referrals coming in, so they had to be triaged, and obviously the urgent ones had to be allocated an appointment and be managed appropriately. So then we very quickly moved on to telephone consultations with patients, and in particular, I was involved with dealing with the low vision patients via telephone. Now, a lot of these patients are elderly, may be shielding, may have comorbidities, etc. So on a personal level, they were extremely welcome of a telephone call. And a lot of them, due to social distancing, shopping issues, various other things, sight loss, they were finding other issues very different. So actually being able even to post them out a magnifier or some lighting, or if there was some urgent ones and they were having issues with maybe falls or burning or cooking or something, we were able to access rehab services with PPE, etc., to go and visit these patients. So if they were agreeable to that. So there was a lot of safety issues were able to be addressed as well. And personally speaking, these patients found the contact, even on a pastoral basis, just extremely useful. So I think that was really very heartening. And I mean, even going forward, we're still doing these currently because a lot of these patients are not able to access clinics. My other role in the Health and Care Board meant that I had kind of had a link also between what was happening in primary care and secondary care, letting the consultants, etc., know what was going on out in the community and vice versa. So it was a bit of a conduit of information to be transferred. But within the Health and Social Care Board, we very quickly established remote working, and that proved very effective and very successful. And the initial work within the Health Board was with regard to the closure of practices and suspension of services in the 24th of March in Northern Ireland. We were lucky enough in Northern Ireland that 270 out of 271 of our practices were able to stay open. And as the clinical advisor for them, there was lots of anxiety, stress, all that associated with, you know, businesses, a new way of working, and, you know, financial concerns and everything. So we had a lot of communication, phone calls able to assist them. And then there was the financial support package, which practitioners needed to know how to claim, how to manage that. So we were dealing a lot with that. And my other significant role was in the procurement and the supply of PPE out to practices, which in Northern Ireland we were able to issue out to all the practices continuing to work, offering essential and urgent care. So the big standout things for me in the pandemic have been, you know, how effective and how quickly a team in eye care have been able to gel together, change the way they're working, and provide effective and safe care for practitioners or patients, both in the primary and secondary care. In primary care, a lot of the practices, you know, clustered together on an informal basis, so they're buddying up with their local, as Tim said, collaboration was really good to see, just, you know, making sure that every area was covered. And they clustered a lot around IP optometrists to ensure that patients were getting care without having to access regional centres, and maybe these patients weren't able to travel. And any comments and feedback I've had from both those in secondary care, ophthalmology, everybody has been really positive, and I think they've been very grateful of the work and the effort everybody involved in the eye profession has put into dealing with and managing patients. So I certainly am looking forward to seeing how all of this will develop going forward in the future. I think it's going to be a very interesting time.
Janice, thanks. That's it's really interesting. It is particularly interesting to hear the sort of familiar themes developing as we've talked to all our guests tonight. That there is that changing roles, but working collaboratively, working so that our patients are benefited. And I think one of the things that's been particularly tricky in England is been sourcing PPE. So I think, you know, hats off that you've worked hard to make sure that practices have got access to that. So again, as we've asked our other guests tonight, what are the sort of lessons that have been learnt? How things maybe will change going forward, and your view for the future. It'd be great if you could share that with us as well, please.
Yes, Colin, I think it will be interesting. The main thing for me was initially everything has become so remote, and all these electronic platforms, I think almost I'm becoming as good as my elderly father at all this technology. However, on a more serious note, I have noticed a great appetite, especially in the hospital eye service, for seeing and doing things differently. I mean, there's a great recognition both to what hospital optometrists can do and those in primary care, and how they can manage patients in different pathways, and how they'll be able to establish care for patients. I mean, going forward, the hospital will have challenges with CV-19 restrictions and patient numbers, and obviously dealing with these backlogs. And as you mentioned earlier, there may be a significant number of patients sitting out there who have potential sight loss, etc. So I think they now realise that to develop additional care pathways and additional ways of working is going to be very, very important to be able to go forward. And secondary care have very much appreciated IP. I know we keep talking about IP optometrists, but they certainly have come to the forefront for me. And the recognition that they are able to manage patients locally and can manage most things. Our eye casualty during lockdown had a senior doctor on the telephone for all calls, and they were able to even work. They were taking videos and pictures and things, assisting optometrists in practice, and a lot of the IP optometrists, both in the hospital and in the community, communicated via WhatsApp groups or various ways as to give ideas and assurances as to how they were managing their patients. Going forward in Northern Ireland, even already, we've seen changes within some of our locally enhanced services to embrace some of the changes that have come in as a result of COVID. our Northern Ireland pair scheme, which would be similar to the MEC scheme in England, has already just issued a new service specification to take account of all of this. For example, now optometrists are going to be the first call for eye problems. You can't access eye casualty without having seen one of your pairs optometrists, and that's one of the changes. And the service capacity, the service has changed a little bit because the capacity in eye casualty will be reduced, and remote consultations are going to stay in as part of the service. And there's been additional add-ons for things like pressure checks, perhaps for uveitic patients, etc., to save them having to access secondary care for what should be a relatively minor procedure, but could be done easily at home or locally in their local practice to save travel. And again, some of these patients may well have shielding issues also. So I think that going forward, there'll be scope for great development for some of these other pathways along the line. And it's really heartening to see how quickly and seamlessly everybody has responded and come together, and how they've worked together, because during all these times, everybody was anxious and worried, and they may have been worried about their finances, their businesses, their staff, their health, all of these things. And everybody's been really adaptable, both professionally and to the personal challenges, and has risen to them. And certainly I found the college guidance quite useful from looking at, an update, and it's provided both assurances for me and for other practitioners that they're doing things right, and everybody else has the same issues. When you see a guidance coming out and it's kind of reflecting something you were concerned about, you know that you're not alone in all of this. So the big standout issues for me during COVID have been remote consultations, which hopefully will stay, and as I say, currently are in Northern Ireland, using PPE and actually learning to see patients with PPE, with masks on, trying to get your arms around shields on slit lamps, etc. And the big thing, working together both locally, buddying up with other practitioners in practice, and the relationships formed between hospital eye care and those in primary care, and the use and the part that IP optometrists have played. So I'm hopeful going forward, some of these changes can really be built upon, and we will have new eye care pathways going forward that will really utilize the skills of optometrists.
Janice, thanks. I mean, to hear that there's a real appetite for doing things differently is fantastic, and this is something that I had reflected in conversations I've had with other people in the sector as well, which is fills me with great encouragement for the future as well. Again, it's great to hear that the IP optometrists have been valued within the pandemic, and I think I don't want to preempt what Shane's going to say next, but I think we maybe have got some lessons to learn from Scotland, Wales, and Northern Ireland as to how IP optoms have been utilised, because maybe in England that's been a little bit patchy. But thank you for sharing that. Great to hear that the college guidance has been reassuring to you as well, because I know the team at the college have worked hard on queries coming in from members to develop the guidance. So thank you for sharing that. So now we're going to come to the lockdown experience in England and welcome our final guest, Shane Abbas Bhimani. So hi Shane, welcome. Shane, you're a clinical director at Specsavers in Hemel Hempstead and London Colney, and an optometrist who works in the glaucoma clinics at Moorfields Eye Hospital. So I'm looking forward to hearing whether and how you've managed to maintain those roles, maybe how significantly they've changed during the lockdown, whether you've had experience of queues, the COVID urgent eye care service, and other guidelines and initiatives. So it'd be great to hear your perspectives. Thanks.
Thanks, Colin. And thanks everyone for joining us this evening. Gosh, it seems ages ago now, but I think it's a pivotal point in everyone's life. No one is going to forget 23rd of March anytime soon. I remember that I just finished my clinic at Moorfields, and I was actually on my way out of the hospital when I checked my phone, and I had 17 missed calls from the practice. And gosh, you can imagine what was going through my head, the absolute worst. I called them back and I got through, and I've been told we've cancelled all the clinics and we've put everyone on furlough. I think, okay, bear in mind this is over 50 people. I was mortified, shocked, mixed emotions. I didn't know what to think. But it was 6:30 in the evening. I was on my way home. We had some communication later on that evening, and they said we should cease testing and offer just a remote service, essentially. So just via phone, and PPE was on its way, but we didn't know what was going on. So going in the next morning was one of the hardest things I've had to do. I remember walking through the town centre, and it looked like a ghost town. There was no one. Very easy parking, but not in a good way. I opened the store, the phones were going crazy. I tried to pick up what I could, but it was impossible to manage. I'd answer one and the phone would just constantly be ringing. The next few days got even harder. Trying to help people in need, firstly without PPE, so closed doors, telephones only, but also my skills were out of date. Trying to do dispensing on previous orders, how do I do it on the IT system? We then had glazing, how do we do that? Everyone's on furlough, how do I turn these machines on? And quite frankly, I was scared. I was coming to work, going home. I wasn't even sure we should be open in the first place. And I think initially there was no support from our professional bodies, not through anyone's fault, but I think it's just that no one expected us to end up where we did so quickly. No one planned it and no one knew what to do. So fast forward a month, I think things got a lot better. Guidance started coming through. We had sourcing of PPE from the LOCs. The videos were commonly available on YouTube from NHS on how to don and doff PPE. It was all becoming more widely available. The college updates I found have been really good. Now, they've updated it daily and they've really given me guidance as to what I can and can't do going forward. Taking an example, the ceasing of NCT pressures, moving to eye care and then re-establishing NCT pressures. That said, staying open has meant that we've been there for our community. We're the only opticians in town that stayed open throughout the pandemic. It has meant we were able to pick up several papillodemas. I had no idea this condition was so common. I've kept in touch with all of those patients and I can assure you they're delighted with us, and I'm glad that we were able to serve them in their time of need. Looking at the broader picture, I think it's really opened the public's eyes and perhaps the government's eyes into what we're capable of as a community when we work together. And it's essentially really catalyzed the development of universal funded urgent eye care services that haven't really been changed since the introduction of GOS services. And the final point is the point of remote care. I think it really shows how we're able to adapt going forward through anything, essentially, especially if things go pear-shaped.
Thanks, Shane. Just switching my camera back on again. I think it sounds as if you went through a really tough time initially, and I think everyone was in the same situation, wondering, gosh, what on earth is actually going on? I suppose I have to maybe leap to the college's defence a little bit here and say, I mean, they may have appeared to be slow to react, but of course we need to wait for information and guidance to come in so that they can give us the correct information. So we try to react as quickly as we can based on the information that's available at the time. And I think the point about a universally funded eye care system makes good sense. I mean, Tim spoke earlier about private patients subsidizing NHS patients, which is, I think something that we all realise that in England we're maybe lagging behind some of the other nations as well. So maybe with that in mind, I mean, what do you maybe feel will change? How do you see things in the future in England?
Well, it's a tough one, but one thing that I hope doesn't stay around is PPE. I know that Janice said about keeping it along, but I find it very uncomfortable and not easy to test and talk in and things like that. But I understand that it's a necessity, hopefully short term from my view, but I understand the need for it. Right now, though, I haven't felt prouder of being an optometrist. The actual respect and we get from patients and the receptiveness that they have for what I say in the test room, I've never seen this before. They're also more forgiving and understanding. Before, if you were even a few minutes behind or so, that they said, look, I understand you're taking off PPE, putting on PPE. I understand the delays and things. Don't worry about it. So I guess going forward, firstly, from a patient's perspective, is I hope we get the similar level of respect and appreciation that we're getting right now. In terms of serving the public, I've never felt more efficient. And let me expand on that. Remote care, particularly video consultations, has enabled us to look at conditions that patients foresee as extremely sinister. So something like some conjunctival hemorrhage that they think they wake up one morning, they don't even realize what's gone on. And it's only till they speak to their partner or someone who says, gosh, what's wrong with your left eye or so? And they're straight on to pick up the phone. And I think looking at that person face to face and then explaining it to them on a video has meant that we're able to essentially free up capacity, free up the diary for people who really, really need us at this point in time, because we haven't really been able to offer a service properly for 3 months. So there is a huge backlog that we need to get through. From my role in Moorfields, it's been a lot more of a helpline, speaking to those patients who are worried. We're now delaying appointments that were initially meant to be seeing in March. They've been pushed back about 6-7 months. So a lot of these patients are anxious, what's going on? And remember, glaucoma is insidious in nature. So patients don't really know that they've lost visual field until it's happened, and it's irreversible. So, and they know this. If they suffer, they know that this is happening. So it's about talking to them, perhaps looking at certain objects in their room, perhaps a lamp or something, and saying, if you look straight ahead, are you able to see it? Can you still see it? Is parts of it missing and stuff? Really adapting the clinical care you're able to provide. The other thing is manning the A&E helpline. We get a lot of dry eyes, and I think the doctors who are in the front line are grateful that these people are not walking in through the A&E clinics, that we're able to say, look, just go in, see your optician, get some dry eye drops, and if that doesn't work, that should help. Going forward, I really think we need to embrace this technology change. And that's the only way we're going to understand how to evolve and really deliver what our patients need, and specifically to deliver what that patient in need, real need, really needs. I think England needs to follow suit of Wales, Scotland, Northern Ireland. We were talking briefly about before the webinar started, about the seamless integration that Northern Ireland is able to achieve between primary and secondary care. And I really think it's something to be envious of. This merger of secondary and primary care has to happen to allow more fluid patient care, more seamless, and really prevent blindness. But I think this can only happen if we have the support, both structurally, so sort of systems are set up, but also financially from the NHS. We know payments have continued in other areas where they've stopped in NHS England for NHS, and that is a debate that I could talk about all evening, but I won't. But it's nice to finally see that we're getting our skills really taken advantage of. My final take-home message is to all of those listening is, a few years ago, I read a book called The 7 Habits of Highly Effective People, and I highly recommend it. Habit 7 is to sharpen the saw. And after the pandemic, I think it's really important not only to keep the saw sharpened, but ensure that your whole toolbox is in working order. I think it's important because when you're exposed to something that you have not done for a while, such as dispensing, because I hadn't done dispensing for a few years, it's a real shock to the system, thinking, oh, what are the heights of this? How are we going to fit it in? And it's not as easy as riding a bike.
It certainly isn't. Thanks a lot, Shane. I think we've all had to look and develop new skill sets. So I think some great points there. I mean, from again a personal perspective, I find PPE in clinics is incredibly cumbersome, but yes, definitely it's here to stay, isn't it, for foreseeable future. And it's great to hear that your patients are giving you respect and admiration for the work that you do as well. I think the backlog is an interesting point as well, because I know both primary and secondary care will have backlogs of patients, and it'll be a real challenge to see how we're going to meet those needs going forward. So thanks very much, Shane. So before we move on to our Q&A session, we have another poll question for you. It's really just to get a measure of how everyone's feeling about the future of optometry post-lockdown. So it's a very simple, straightforward question. So how are you feeling? Optimistic, pessimistic, or no different? So let's just see. As the votes come in, I can see everyone's voting quite quickly, which is fantastic. I think maybe listening to our panel tonight, I don't want to influence the vote, but I would feel optimistic for the future. But it'd be really interesting to see how our people that have logged in tonight feel. So we're getting to nearly everyone voted, which is fantastic. I'll just give that a few more moments. And let's see. Oh, well, that's really great. So the majority of us are feeling optimistic, a few pessimistic, and I suppose it kind of depends on where you find yourself today, because as I said at the beginning, there is a huge amount of impact on the sector, and there has been some news over the last week maybe that's not been so great as well, with you know, potentially people looking at their future and thinking, well, I still have a job. So it is, but it's great to see there is a sense of optimism. So I'm going to ask everyone to join me again so we can have a bit of a Q&A session. I've had some questions come through, so I'm just going to have a look and see what we can answer. There's been a few really interesting ones, so I'll just see what we can start off first. So I think we picked up on the collaborative point, and this is maybe something that we could go around everyone and just ask how they feel that maybe primary and secondary care services can work closer together in future, and maybe what needs to happen for this to work effectively. I mean, from my perspective, the college has been picking up regularly with the Royal College of Ophthalmologists, and there is a desire to work closer together, and I think there's a greater understanding among ophthalmology that funding needs to be in place to enable this to happen, and that the GOS system, maybe as it stands in England at the moment, doesn't quite enable us to do the kind of things that we want to do. But it would be really interesting just to hear other people's views. I mean, Shane, I think if I was to come to you first, you kind of alluded to this when we were talking about funding, but how do you work in primary and secondary care? How do you think maybe it could work a little bit better and closer in future?
Thanks for the question. I think what we need to do is leverage safe technology, and we're using something called Pando Moorfields, which enables us to seamlessly speak to other practices and upload them onto an intranet and things, and for other practitioners to draw data down as well. And it needs to happen universally, but also there needs to be a clear funding, say this is what a GOS will cover. Oh, this patient is presenting with this symptoms. This is what you need to code them as, similar to what Scotland has, where they have the supplementary and the main eye examinations.
Okay, great, thanks. I think, I mean, Kathryn, you've had first-hand experience of the situation in Scotland, and you talked about the collaborative side of things. What were the things that you felt made it work effectively for you during the pandemic?
Well, something that I wasn't using personally, but in the emergency eye care treatment centres, an issue that has been a long-term restriction for primary and secondary care working well together is the IT systems. So being able to access secondary care patient records so that there's not the duplication. So for example, with diabetic retinal photography, so that we're able to save the patient multiple journeys. So they were able to provide that for the emergency eye care treatment centre, so they were able to access the patient's current management plan, and that would be lovely to be able to roll out into all of primary care, not just those hubs.
Yeah, I think connectivity is a big issue, isn't it, really, to be able to share patient information. I don't know, Janice, if you've got any thoughts or experiences on that with the roles that you have, both within the Health and Social Care Board as well as the hospital?
I think Northern Ireland seems to be quite lucky in that their IT systems seem to actually, when I hear where other folk are, we seem to be quite far advanced for being so out west, as they say. But I mean, our optometrists have access. We do electronic referrals now. If you're on, that there's access to, or the ability to access electronic referrals. So you're not going via the GP. You're automatically sending them electronically to the hospital. We, as optometrists, if you have that same platform, and the vast majority of practices are, it's about electronic claiming. You get access to your electronic referrals. You also then have access to the electronic care record, which is really the patient's health record. And you'll be able to see if they've had appointments at pediatrics, if they've had, diabetic. You've got a full access, and you can see that in practice as well as in the hospital. So you've really got links as to where the patient's been, if they've been to the glaucoma clinic, should they be using drops, etc. So you get sight of the letters and things that were sent back to GPs by just logging on. So that's really useful. And I think, that collaboration, you need all that. But definitely, I think it's a synergy. Secondary care needs primary care, and primary care needs the hospitalized service. So it's a win-win.
Yeah, and I think that the whole pandemic has shown up that the two of us need each other, and that we should be trying to work more collaboratively together. And Tim, from a Welsh perspective, would you have anything you would want to add in there?
Yeah, on a similar theme, really. I think my own experience, I've been a clinician, a contractor, and been involved with the health board. What I haven't had experience of is being a patient. If I had experience of being a patient, I wouldn't care what the name above the door was, whether it was in primary or secondary care. It's just got to be treated. And I think that's what our aspiration should be, is that eye care is a singular team that is made up of lots of different skill sets that are delivered in different places. For that to happen, I think we need a really robust and honest conversation about why it didn't happen years and years ago. So we can explore that. As you mentioned, Colin, the Royal College of Ophthalmologists working together with the College of Optometrists is really great. And I think when joint statements are released, that's really powerful. So that's really good. But the single biggest thing is the electronic patient record. The IP optometrists working across Wales have been really successful. There's been one health board that's had access to an electronic patient record, and that's been the audit of their service has been fantastic. Very few patients were referred into secondary care. The vast majority were managed by the IP optometrists, but there still remain 25% of patients which were managed in primary care, but only with either discussion or access to those secondary care notes. So that's a quarter of the presenting patients can only remain in primary care if you have a fully functioning electronic patient record. So we're thrilled in Wales that over the last few days our health minister has signed off to release the funds to allow every health board in Wales to have that. We're really excited about what possibilities that means for patient service and care, but also for those relationships to grow over time, so that it does hopefully become the norm of our future.
Great, thanks. I mean, I think the sharing of information, having access to all patient information. It just helps so much with the bigger picture, doesn't it? You see the patient as a whole. You're able to manage them as a whole. It's just it's a much better way of working. The next question we've got is around patients and the time that we spend with them, and there seems to be a great preference for patients. They like the greater time that we spend with them, but I think from a business perspective, how does that work? How would we survive financially? From my perspective, working in the hospital, when I'm seeing patients, they do like the longer time that we spend with them. But from a business perspective, I might have to come to maybe those of you that are in practice or practice owners. So I don't know, Tim, if you've got any thoughts on that.
Certainly, I think patient care is really important, and the patient needs to feel that they've had the right service done. But we need to think more about the service itself, I think, rather than the person delivering that service. And we're seeing that really with upskilled and contact lens optometrists and delivering the services, and really utilizing all members of the team. How can we upskill every single person in the system to allow the right service to be delivered that doesn't rely on one or two individuals within the practice? And I think that's probably the key to how we still deliver the best service for the patient without toppling over financially.
Yeah, it's an interesting point, isn't it? And Shane, from your with your business head on, what do you feel? I know some practices have talked about maybe looking at their fee structure and having to say they're going to have to charge more for the time that patients spend with them.
Yeah, I think there's definitely going to be a change in the costing system for businesses to survive. But I think also one of the key things that I learned, or I was taught by my pre-reg supervisor, was to work smart and not work hard. And as long as you're efficiently working through your test and doing the tests that need to be done, you're going to do right by your patient. And to go back to Tim's point earlier, the patient doesn't care about the name on the door and things like that. They just want a fix to their problem. And maybe I'm speaking, and I don't mean any disrespect by this, Colin, from a younger generation, but I'm sort of the person who's get me in, fix me, and get me out. If there's a pandemic going on, don't keep me there any longer than I have to be.
Yeah, that's an interesting point as well. I've been sort of quite surprised by the demographic of some of the patients that have been presenting, and thinking, I wonder if you maybe shouldn't be out and about at the minute. But it's that's a whole other issue, really. So there's a couple of other questions that are kind of more clinically based, with practitioners wanting to know what they should and shouldn't do in certain situations. So I think I might defer those to the college clinical advice team. And as I said earlier, if there's questions that we're unable to answer as a group tonight, I think we'll get those on the college website when the recording goes live later in the month. So we'll maybe keep the more clinical ones because they're quite specific. But maybe a good one, which again, I don't know if we've really got the answer to, but is PPE here to stay post COVID-19? I don't know what people feel on that. It's certainly something we've never had to deal with as a profession. I think we've embraced it and adapted to it really, really well and really quickly. But I don't know, Janice, you were involved in sourcing it. What are your thoughts going forward?
Well, I mean, I have to say, I think it's been quite a challenge for optometrists, because as undergrads, we're not taught infection control. I mean, even basic hand washing and, sterilizing things, that's in our, that's inbuilt in nurses and things. We're not taught that. So we did have to sort of upskill quite quickly. Certainly, whilst there's still a risk of infection, my opinion is that the PPE will have to be utilised. I mean, we've even moved today for people going shopping needing to wear masks in most of the parts of the UK. So I think, until the COVID risk or the CV-19 risk has gone. I think we are just going to have to live with it. It's one of those things we're just all going to have to learn to embrace. I don't know what everybody else thinks. I mean, and there are the cost issues and stuff with it. I mean, that's another. We've been lucky enough in Northern Ireland to be able to provide at least some, but going forward, it's going to be an ongoing battle because, you know, from the 1st of August, VAT is now applicable on PPE, and it wasn't until then. And, you know, the cost of it have rocketed.
Yeah, that's a really interesting point as well, isn't it? It's an added cost onto practices and to the health service as well. Kathryn, in Scotland, what do you think? Here to stay?
I hope not, but that's a personal thought. I think it really interferes with being able to assess patients in the way that you'd like to. So if it's not needed going forward, once the infection risk is down, I think it's easier to do things like pluck lashes, whatever, without wearing gloves.
Yeah, I mean, it's tricky, you know, even things like applying a contact lens is difficult with gloves on, isn't it? So yeah, presenting great challenges. Tim, if I could come to you next, what are your thoughts on this one?
Well, I think it's interesting. I saw a study on how other European countries were looking at it, who may be a little ahead of the curve, and there was a real split there. So it's definitely something that does split the profession. There was a split between people thinking that the patients should be wearing the PPE, that they should be wearing the PPE as clinicians, or that nobody should, or that everyone should. You know, so it's one of these things that people have an opinion on. And I don't think we're used to that as a profession. We're used to being quite protocol driven and knowing what the right thing to do is and absorbing that. What I have found refreshing though, as much as I don't like holding my breath all day in PPE, what I have found refreshing is the patients come in, and a lot of patients have said, why are you doing all this over the top stuff? Why is it so clean in here? It isn't in the shop next door. And we can simply say, because we're not a shop. I think for a profession that aspires to be ever more clinical, that's no bad thing.
Yeah, absolutely. Thanks for that. And Shane, I think you said earlier you hoped it wasn't here forever. You wanted to be able to dispense with it sooner rather than later. But again, it is a tricky question. I appreciate. But what do you think?
It's a needs must, I guess. We know that from the 24th, and sorry to call us a shop, but we are on the high street. Shops are going to need to wear PPE. The patients or customers are going to need to come in with masks on. But I think the ultimate thing is also, to Janice's point, is the cost, because it does have this cost behind it, and someone needs to pay for it. Whether it's, I don't know, God forbid practice closes because they can't afford PPE or haven't come up with a sustainable business model that sees them through the additional costs and stuff. But let's not forget that we're still providing GOS services in NHS England that haven't changed for 5, 6, 7, 8, if not more years. Hopefully now we'll be able to get more for more than 21.31.
Great, thanks. So I'm just conscious of time. I think we've covered a lot of the questions. As I said, we'll maybe leave some of the more clinical ones to the college advice team. But we've just had an interesting comment come through, which I think it's probably worth just reading out. So it's not a question as such, but one of our listeners tonight has said that COVID has demonstrated just how much optometrists have stepped up with queues and with IP, and what could be achieved if it's properly funded and consistently commissioned. The reliance on the cross-subsidy doesn't promote better clinical and referral outcomes. Ophthalmology services are and will continue to be heavily impacted and can only recover with the support of optometry. So, you know, I think that's echoing the thoughts and the views of you as panelists and the people that I've talked to, that, you know, optometry is in a place where it can help and support, and there are opportunities to grasp, and I think there is reason to feel optimistic for the future. So so thanks really to everyone for joining this evening. I think it's just for me to thank all of our guests for giving up their time tonight, and I mean, I've really enjoyed the conversations and listening to the experiences. So thank you all for joining. I think we can all maybe take away some learnings and some ideas, and I know there's lots here that I'll be taking back and discussing with my colleagues at the college. So thanks everyone, and well, hope to catch up with you all soon.